All right, ladies, hello, hello. I hope you are well. I am here with Dr. Georgeanne Freeman, and we're going to be talking about hormone replacement therapy. And apologize, we had some technical issues, but we are here, and I'm super excited to dive into this topic. And before we get to going here, I want to introduce Dr. Freeman. So Dr. Freeman is a family doctor in Austin, Texas, and runs a clinic there called the Freeman Medical Clinic. And we've been kind of chatting back and forth for a couple of months now. And I knew that Dr. Freeman was, interested in the topic of hormone replacement therapy. So I asked her if she'd be willing to jump on and tell us all about it, because I know it's a confusing topic for many. So thank you so much for joining us today and taking some time out of your busy schedule. We really appreciate it.
Oh, it's my pleasure. You're welcome.
Awesome. And also, if ever my internet freezes a little bit, it does happen because I live in a very remote location. So it may freeze, but it doesn't happen for very long. Okay, so let's dive in here. Why don't you tell us what got you interested in just the whole field of hormone replacement therapy? Just kind of take us from there, and then I've got some questions that I myself have, and then a lot of women also told me what they wanted to learn. So, but tell us how you got interested in this topic.
Yeah, so when I was a pretty young doctor in my late 20s, early 30s, I was practicing in a very rural area in the Ozark Mountains, and I had a patient who was a nurse going through menopause. And this was in the time when Oprah was having Suzanne Summers on her show. And Suzanne Summers had just written her first book about hormone therapy, was getting a lot of press. And women in this remote area where I was wanted hormones. You know, the cat was out of the bag because Suzanne Summers was talking about it in her book, and Oprah was all excited about it. And because I was the only female doctor they had in this area for a long, long time, this one nurse in particular really led the charge for the community, and just kept telling me, we need these hormones. And I said, well, maybe so, but they don't really teach us about hormones in medical school. And the Women's Health Initiative churned out this data showing that hormones increase the risk of heart attacks and strokes. And I'm not interested in doing anything controversial. It's hard enough being a woman doctor out here. People look at me funny. And if I ever talk about stretching, the next thing I know, I've been labeled a witch. And, we wouldn't even use the word yoga back then. So really did not want to be involved in anything controversial. But this nurse was very persistent. And she just kept on me. And at some point I needed some continuing medical education credits. And like happens in life when you're in the flow, something probably wasn't the internet back then, probably something came in the snail mail advertising a hormone conference in Dallas. So in my home state of Texas. And the doctor who Suzanne Summers found in a basement in Harvard and pulled out of almost retirement, and he spotlit using plant parts to get hormones to do this bioidentical hormone therapy, was the keynote speaker. And so I couldn't argue myself out of it. I went to this A4M, which is the Anti-Aging Academy, something or other, it's 4 A's, put on this long weekend conference in Dallas. So this would have been in the early 2000s. And I went, and it was evidence-based, but it was also a lot of testimonials, and it was 4 days of drinking from a fire hose of information, and I was hooked. I wasn't anywhere near menopause then myself, but I came back to the Ozarks, and I did find a compounding pharmacist, actually not too far from where my little clinic was. and worked with her, and we brought bioidentical hormones to women. And so I got to see women crying and expressing all this gratitude and explaining how much better their lives were. And I just really didn't know much about it at all before then. But doctors go to medical school because we want to help people feel better. And this was like so profound and so fun. And so I never quit doing it. And then when I went through menopause, I had all this confidence because I know what is an option, not anything one has to do, but having those options feels really good. So that's how I got into it. And it's my passion. As you can probably tell, really love helping women figure out these hormones. And also I like helping women decide that hormones aren't for them if that's not for them. But, you know, just having that choice over our own healthcare feels great.
Yeah, yeah. And I think that's sort of like a really important point, is that some women will decide to take it, some women won't. But I think it's really important for women to educate themselves so that they can make an informed decision, because I still think there's a lot of doctors out there that don't quite, as you said, they're not getting trained on hormone replacement therapy. And so they might not be in the best position to provide the information required to help women make that decision. Now, you mentioned the Women's Health Initiative, and I mean, I'm certainly not a hormone replacement therapy expert, but I do read a lot about perimenopause and menopause and hormones, and I listen to a lot of doctors in the women's health sphere or space talking about hormone replacement therapy. And one thing that comes up quite often is the Women's Health Initiative, and how when those tests, when the results came out, hormone replacement therapy got a really bad reputation, and that reputation has kind of stuck, even though, from what I understand, they later realized that maybe they made a mistake. Can you kind of explain what the Women's Health Initiative was, what the original results were, and then what they kind of later discovered that never really got mentioned in the media?
Yeah. So you're right to focus on the Women's Health Initiative. This is the crux of the matter. So before the Women's Health Initiative, before my residency training, I happened to be in residency training when the Women's Health Initiative data first started coming out. So before then, it literally the last century, women were put on estrogen, usually estrogen and progesterone, for their menopause symptoms. And so it was very common, and it was done, and it helped a lot of women feel a whole lot better. Estrogen and or progesterone. Okay. Then the Women's Health Initiative was the first longitudinal huge study looking at a group of nursing students and nurses and drilling down into their health habits to try to figure out what habits are health promoting, what habits might be not health promoting. So things like smoking, things like wearing seatbelts, which I know we all do now, but not everybody was doing back then. The Women's Health Initiative looked at a lot of things like that, but there is, and I promise y'all, I'm not going to get way into epidemiological science speak, but I'm going to use two terms: causation and correlation. So y'all probably know this already. When the rooster crows and the sun rises, that happens at the same time, but the rooster crowing does not cause the sun to rise. These are events that are correlated, but they're not causative, right? So there was a lot of jumping to the conclusion that taking estrogen caused an increase in heart attacks or strokes. Well, as soon as it looked like that was the case, whether it was estrogen combined with progesterone or just estrogen, doctors immediately said no more hormones. And it's not that they are trying to hurt women, it's that our Hippocratic oath is to do no harm. So if there's something that looks like it's harming, we're, it's like touching the hot stove. We're, hands off. They responded very aggressively, and it just went from something super common to absolute zero. I don't think any doctors in the late 90s, early aughts were prescribing hormones at all, because we were told, it could increase the risk of heart attacks or strokes. And then even like every 4 months or so, as this data was churning, we were fascinated to watch the data. It was way too much for any one person to interpret, but it was a fast scurry to try to interpret a lot of things. I'm just going to stick with the hormone part. So then it started looking like, oh, well, it's not really so correlated with estrogen only. It looks like it's more estrogen and progesterone, or if a woman was on progesterone alone, that increased the risk of heart attacks or strokes. So then progesterone kind of became the bad guy. And maybe some really brave doctors, if a woman begged enough, would start, again, prescribing this estrogen, which back then came from pregnant horse mare's urine, Premarin or Prempro. So we had that. But even now, decades later, epidemiologists are still interpreting this data because there's so much data that came out of that Women's Health Initiative. And when you factor the ages of the women, the health habits of the women, there is no causation or correlation definitively between having a heart attack or a stroke, cardiovascular event, cancer, and taking hormones.
Okay.
Now, there have been other studies done, because we all want to really know the answer. We want evidence that says, does taking estrogen in any form increase your risk of breast cancer, uterine cancer, any kind of cancer, heart attack, strokes, anything that would be bad for us? And there is no study to date that can say that hormones are 100% safe, or that hormones are 100% not safe. But the preponderance of evidence of women who we can look at now who take hormones we are not seeing higher rates of cancer. We're not seeing higher rates of heart attacks or strokes. So it is accepted among my peers, and it is considered standard of care among people who really know this science to prescribe hormones. And you were very kind in your comments earlier about doctors not understanding or being knowledgeable. It is way worse than that. And I'm a Western medicine trained doctor. Like, it's just horrific that we get almost no training on this in medical school, almost no training on this in residency, but it is what it is. So ladies out there, what you want to look for is a doctor who loves and is passionate about hormones. And so you just want, the questions you want to ask are, where did you, or did you get extra training in these hormones? Because someone who's really passionate is gonna be like, oh yeah, and you don't need to know where they went, but she'll be, or he, but usually it's a woman, will be excited to let you know that they actively pursue conferences on hormones. And they have to, because I can tell you they're not getting it in, to my knowledge, even today, medical school or residency. It doesn't have to be an OBGYN. It doesn't have to be a family medicine doctor, but you just want to find someone who is seeking out actively getting that training outside of their basic medical training.
Okay, that's good to know, because I know a lot of women are frustrated with their doctors when they go to see them to explain how they are experiencing perimenopause and menopause, and they're not getting the support from their doctors that you would expect, because women go through menopause. There's no way around it. And so it's crazy that there's no training on this topic, because for so many women, it has such an impact on their physical health, their mental health, their risk of disease if they're not educating themselves on how to take care of themselves, or if they're not getting the support. So it is kind of crazy. But okay, so is there anyone, now that we've kind of clarified that from what the research is showing, there's no definitive correlation between hormone replacement therapy and an increase in heart disease or cancer. Is there anyone that should not be taking hormone replacement therapy?
Before I answer that question, and I promise I'm going to answer that question, I do want to say that there is evidence that using estrogen in the postmenopausal female decreases the risk of bladder cancer.
Okay.
Promotes cardiovascular health. So,
can you explain, because this is really huge, and I talk to this a lot in my workshops and especially with my clients, the role of estrogen, because I think a lot of women think that estrogen is just about their menstrual cycle. And from all of the research and reading that I have done, I understand that estrogen is so much more than just regulating our menstrual cycle. And in fact, it is protective of so many elements of our health. And so when we are postmenopause and we don't have estrogen to protect us, there are all these things that can happen. So can you just kind of just help women understand, like, beyond the menstrual cycle, why do we need estrogen?
And let's not forget the third player. So I was very clear to point out that the Women's Health Initiative looked at estrogen and progesterone. Back then, doctors were not paying attention at all to testosterone in the postmenopausal female, which is huge. And I have many women who are on very little, sometimes no estrogen, but they don't ever get between them and their testosterone.
We can't get it here in Canada. We'll talk about that after. It's a really hard one to get. I've talked about testosterone before. We're going to come back to that.
Definitely need to talk about that. Okay, but I want to make sure I answer your question. So estrogen has everything to do with blood flow. So yes, certainly in the menstrual cycle, but how it's protective once our bodies stop making estrogen or make less estrogen is that now you have, like, picture the human body. There's blood flow from your brain all the way to your toes, all the way out your arms, into your fingertips, and everywhere in between. It's all this blood flow, right? So when you have less estrogen, you have less blood flow, because the estrogen helps facilitate that. That's why after a certain amount of time with no estrogen, your vagina gets dry, your ears get dry. Things that are on the more peripheral of your body are going to get drier first, because they're further away from the heart, and the heart is what's pumping that blood, right? And the vessels near the heart are larger because they're bringing that, not that big, but they're bringing blood from the heart to the rest of the body. And then the vessels, the arteries and the veins get smaller as you go away from the heart. So by the time they get to the fingertips, the vagina, the penis in males, yes, males have estrogen too, those areas can get drier. And that's why when you take estrogen, the circulation gets better. And that's how it decreases the risk of bladder cancer. I'm not going to go into all the details, but a fun fact.
Okay, so testosterone.
Yeah.
That's an interesting one, because you can get it in Canada, but like I can't go see my naturopath. My naturopath cannot prescribe testosterone. It can only come from my doctor. And a lot of doctors, from what I understand, a lot of doctors in Canada do not recognize why women would need testosterone. So let's take like just quickly, why do women need testosterone and how can it benefit them? Because I know it's been a game changer for a lot of women that I've talked to, but can you explain how testosterone can improve a woman's quality of life?
Yes. In the US, naturopaths can't prescribe testosterone either. You would have to get testosterone from a medical doctor. I think that's appropriate because testosterone, there's a lot that goes into that. Testosterone is a controlled substance. It is an abused substance. I think it should be prescribed by a doctor, but I think doctors should know how to use it and prescribe it for women and men, going through andropause or menopause. So how I break down the hormones, and this is not hard and fast, but for fun, like if we had 3 circles, I usually draw this on a piece of paper, but let's say we have estrogen here, progesterone here, and then testosterone here. Like a Venn diagram, there are 3 things, but there's going to be overlap, right? These 2 things are going to overlap. All 3 are going to overlap. I don't have 3 hands. But in general, testosterone does what you think it does, what it does for males. So I like to say, hey, think about a male going through puberty. So it can lower your voice. That can be permanent. It can give, I'm going to go through the bad things first, or the potential negatives first. It can give you hair in unwanted places. Okay. Just like a male going through puberty. It can give you acne, even if you never had acne or pimples before. Then the other things, increased sex drive, increased energy. This is by far and a wide the most common complaint I get from women who are going through perimenopause or menopause is fatigue. Hot flashes is probably number 2, but usually they come and weight gain. Maybe that's number 3. And it's often all of it, right? But women come in dragging ass and they're like, I am so tired of being tired. And I will usually, of course, I check hormone levels first, and usually their hormones are 0 or low if they're perimenopausal. But even if their hormones are within the normal range, if they're symptomatic and they're over 40, there is nothing wrong with trying some hormones. And I usually start testosterone first. Women think they want estrogen, but depending on their symptoms, if they come in and it's hot flashes, a dry vagina, I'm going to start the estrogen first. But if it's fatigue, weight gain, I put them on the testosterone. The other thing that testosterone does, and I want to have a big argument about this, is that it decreases brain fog. So often women will come in and say, I just feel foggy. I feel like there are cobwebs up here. They're kind of describing brain fog, but often women start on hormones. They didn't even really realize that. But when I clear their brain fog, they come in and they go, I swear I'm thinking more clearly. Now, as a female, I kind of hate that that's a main role of testosterone. I'm not saying men are smarter, but and it's known very, very, very clear that women make estrogen, progesterone, and testosterone going through life. Yes, we have more estrogen in the ratio compared to men. Men have more, they make more testosterone than estrogen, but I don't know why it's such a blind spot for doctors to just not even factor testosterone in for the menopausal woman. It should absolutely be in there.
I know this is one of the questions that a lot of women asked, was like, if you like, if I go to my doctor and I say, look, I'm 48 and I'm tired all the time, and I'm whatever, I can't think straight or whatever. Like I'd like to explore testosterone, and they look at me and they're like, no way, you don't need testosterone. Is there, do I find another doctor? Is there anywhere, like, how can I take control of my own health and advocate for my own health if I have a better understanding than my doctor because I've done the research, but my doctor doesn't want to listen? Do I just find a different doctor? Or is there somewhere we can send our doctors to help them get up to speed? Or
I just had the thought that I should do a training in Canada.
you should.
I should totally do a training for doctors who are interested in learning about hormones. And as you know, I love Canada, like a lot. I spent a lot of time in Canada. And as soon as I said that, I was like, Canada, schmanada, like I should probably do that in the US. Anyway, I think the best thing for a particular woman would really depend on her circumstances. So if she's in a remote area, she wants to find a doctor like me who will treat her through telemedicine. But I don't have a Canadian license, so I can't help the ladies in Canada. But if you're in the US, you can see me. I can see, we can send medications through the mail. I also love to educate, as you can probably tell. So if you have a doctor who you like, I would say, remember the only reason I got into this was a nurse who was persistent, pushy enough, but not so pushy as to make me be like, oh my God, no. She just really encouraged me, and she did use guilt. She used a lot of tactics, but she got the ultimate result. And so I would say, suss it out. If you like your doctor or your nurse practitioner or your naturopath and they're ignorant about hormones, maybe ask, is this something that you would be interested in offering? Like, I like you, I like our relationship, but honestly, I mean, much better ways to phrase this, I'm sure, but you don't seem interested, or you don't seem knowledgeable about hormones. Would you ever consider going to a conference? I understand that y'all don't get a lot of training on this in med school or residency. Like there's nothing wrong with just asking. There are plenty of things I really don't enjoy doing in medicine. And if my patients ask me, are you going to do this? Would you do this for me? Especially people who've been my patients for many years. I'm real clear about, nope, going to send you to a specialist for that. That's not my area of expertise or interest. So there's nothing wrong with asking. A doctor shouldn't be defensive. They should be clear. But doctors are humans too, so it might not always be a pleasant reaction. But if you're in a more urban area, I would say you really just want to look at people's websites, because someone who is excited and knowledgeable about hormones should really brag on their social medias, on their website. If you call the clinic and ask, their staff should be like, oh yeah, Dr. So-and-so loves hormones. Or we have a large group, and these are the 3 doctors who really are exceptional at managing hormones.
Okay, cool. Because I know that was one of the questions. Can you explain the different, because I know this is probably something that might not be common knowledge, but can you explain the difference between synthetic hormones and bioidentical hormones, and just kind of give us a sense of, is one safer than the other? Should we be looking for one in particular? What do you like to use with your clients? Or maybe you use both, but can you kind of explain that difference?
Yes. So Premarin is synthetic estrogen. Prempro is synthetic estrogen with synthetic progesterone, and they are derived from pregnant horse mare's urine. They can also be manufactured in a chemical lab, and those are synthetic hormones. I will tell you straight up that I have a bias I know this about myself because I wanted to be a naturopath, and I became a doctor of osteopathy because osteopathic medicine bridges the Eastern and the Western medicine. But my upbringing, my thought processes, I was born in 1965, for whatever reason, I will just tell you, I have a personal bias for things that are natural. And I'm aware that this bias is not necessarily supported by evidence. There is, and I have a list of studies that I'd be happy to share with you that you can share with your ladies. There is some evidence that the synthetic progesterone and estrogen might be safer, so decreasing the risk of cardiovascular events even more than the bioidentical hormones. I understand that. I have a master's in public health. I know how to read a good epidemiologic study. I see that. It's not a huge study, and the study has not yet been replicated, so it hasn't been done more than once. Because I have a natural bias that I cannot sit here and tell you is backed up by science, I almost exclusively prescribe the bioidentical hormones. Bioidentical hormones are derived from plants. They have a much more fluid prescribing option. So I can have a compounding pharmacy drill down an almost infinite number of milligrams for estrogen or progesterone. Testosterone is just straight up a synthetic chemical, whether you're a male, whether you're a transgender patient. Testosterone is just synthetic. There's not, to my knowledge, a plant derived testosterone, and it's so well tolerated and safe in all the years and the hundreds of people I've helped. I wouldn't even be interested in a natural testosterone. Does that answer your question?
Okay. Yeah, for sure. Yeah. I would say that a lot of the women that I have listened to talk about hormone replacement, I would say they are all biased towards bioidentical. So that's interesting, because I was under the assumption that bioidentical was safer because it was identical to what the body produces versus the synthetic stuff, and knowing that it came from like the urine of pregnant horses. But so it's interesting to know that there is no difference in or risk factor. Another question that I know was that women wanted to know is it safe to start hormone replacement therapy at any age? Do you have to start before menopause? You know, if you're like 68, 70, can you still start hormone replacement therapy? Like, does age play a factor in determining when you can start?
Great question. And my opinion is that women can change their mind and make their decisions as often and whenever they damn well want to. There is correlation with starting hormones beyond the age of 60 with a higher rate of heart attack or stroke. And this study was a well-done study, has driven there to be a lot of talk of you need to start your hormones early, or if you miss that window, you're over 60, don't do it, because it is going to increase your risk of heart attack or stroke. But when you look at that correlation, it's not higher than women who aren't taking hormones. It's just that heart attacks and strokes are so much more likely to happen as we age. And as we age, that's when we might be getting on some hormones. But I have no problem starting women in their 80s if they all of a sudden want to start some hormones. No, I would never deny based on age.
Okay. And again, correlation being the rooster and the sun, which I love that analogy, by the way. The rooster and the sun happen at the same time. It's not causation, it's correlation. They just happen to happen at the same time. So why would an 80-year-old woman come to you and want to get on hormone replacement therapy?
So some of my favorite patients are these women in their 80s who their husband dies.
And they want to get back out there?
They want to have sex.
Huh. Okay.
And I'm like, I don't say this out loud, but thank you for giving me a reason to try to stay alive. Yeah, it's often sex. It's often also the dry vagina, even if you're not using it as a sexual instrument. It can be really uncomfortable. And if it gets dry enough for long enough, it will start bleeding because that tissue gets very friable, flaky and thin and papery. As with years, less estrogen, again, less blood flow.
Mm-hmm.
So you get it back on some estrogen, and it can just be a lot more comfortable.
Okay. It can also help with incontinence, right?
It can, yes. And that's because you're plumping up the tissues down there with better blood flow. So everything just works better down there. And again, we also know this decrease in bladder cancer. And don't forget, women, you already know this, but yes, it is true that estrogen and testosterone taken in the menopausal state strengthens your bone health. So it does decrease the risk of osteoporosis. Just want to make sure we don't.
Yeah. Yeah. I don't know if women know that, but I think for a lot of women, they think of hormone replacement therapy. I think it's associated mainly with hot flashes, right? I think we think of like hot flashes and dry vaginas, and maybe that's where it's sort of, maybe we don't necessarily understand the different ways in which it can help, with again, incontinence, like moods, right? And like you said, right?
Gosh. Oh my gosh.
Like, because so many women who have anxiety is a big one that comes up with women that I talk to. Can
I speak about that real quickly? Because it's so
yeah,
important.
please do. Yeah.
So I broke it down, and this is big generalizations, and there are overlaps. Remember, this is estrogen, progesterone, and testosterone all in here playing. But progesterone, whoa. Progesterone can, for many women in perimenopause and menopause, solve your insomnia, make you not a bitch anymore because it can stabilize your mood. It can eradicate your anxiety. What's super fun is to get women on hormones and then get them off of their antidepressant, their anti-anxiety, because they don't need it anymore. Also, depression.
Yeah.
Significantly, dramatically help in that department.
Yeah. Yeah. Which is huge, right? Like, I'm in a lot of different menopause groups on Facebook, and there are so many women that are literally struggling through this phase of life. And I think that for a lot of women, it's sad to see them completely struggle if it's a hormone thing, right? Like, if the fix is there, and it's just getting someone to give them that support and that help. So I think it's huge. And I think the more that, like, I'm so happy you're here, because I want women. I know a lot of women are either, some women are scared to take HRT. And I think some women for some reason, have decided that they want to do it naturally. And I get that. But at the same time, like, I don't think there's anything wrong with taking HRT. Like, in my opinion, it's like, why struggle for 10 years? Like, it's not a bad thing. It doesn't make you a bad person or a weaker person to take the hormones if it can improve your quality of life. What about women who have had breast cancer? Because I know this is another big one. Women who have had breast cancer, or women who have a family history of breast cancer. Can they take hormone replacement therapy, or do they need to stay away?
Yeah, so that's $1 million question. And my opinion is that we now are able to ascertain whether a breast cancer was hormonal or non-hormonal. And so if someone's been tested for the BRCA gene, which would be hormonal, and they're positive, they should never take exogenous testosterone. I've never had a woman want. Exogenous means from the outside. Endogenous
Mhm.
means the body makes it itself. I've never had a woman ask me for exogenous estrogen who was BRCA positive. And I would not just straight up say no. I would have a conversation probably with her, especially someone if they had cancer. I would want the oncologist involved in the decision making. But here's how I think about it. When we're making endogenous estrogen before we go into perimenopause, let's say, I'm just going to use a number, and those numbers, of course, really fluctuate throughout your cycle, but let's say 300 is a normal estrogen level in a 25-year-old female. And when you go through perimenopause, your estrogen level goes from 300 to 200. Then you're creeping into menopause, it goes down to 100. If I give you estrogen exogenously and I'm following your labs and I never let you get over 300, probably not over 200 because I want to be cautious and conservative, could having a normal amount of estrogen flare that cancer or cause that cancer to return? Maybe, but it's not like I'm juicing you up with supra therapeutic levels of estrogen. I would just be replacing something that your body was normally making decades ago before you developed breast cancer, because you were a teenager in your 20s. So that's, I don't want to go down this rabbit hole too much, but I think it's a good exercise to think of the tank of estrogen in that way.
Yeah. And again, right? I think it's just it's a conversation to have with a doctor who understands hormones,
Yes. And my
right?
patient
And so if you've
has to
had
have a
breast
mammogram.
cancer,
Yeah. My patients
yeah.
on hormones have to have a mammogram every year.
Okay, that's a good one.
And when they get beyond that, I literally will not prescribe their hormones. I tell them well in advance. But if they don't do it, they are never going to get hormones from me because I'm always safety first.
Yeah. Okay. Women that do not want to take hormone replacement therapy or cannot take hormone replacement therapy, what other options would you suggest?
Well, when you say cannot or will not take hormone therapy, are you talking about estrogen?
I don't know, because this was a question that came in from one of the women. Let's assume estrogen, because I think that's, for most women, I think that's the hormone that they're referring to when they're referring to HRT. So let's say estrogen.
Yeah, so let's say estrogen. Options are soy products, and I would say don't do them, because the reason they work is that they increase the estrogen in your body. So you either have decided to take estrogen or not. So if you've decided not to take estrogen, completely support that decision. Don't mess around with soy that is going to increase estrogen. It's going to make you feel better, but you might as well just go for the estrogen. But you still have on the table testosterone and progesterone.
Okay. So if you can't take estrogen because of whatever X reason, it doesn't mean that you can't look into progesterone and testosterone as a means of improving quality of life.
For sure.
Okay, that's really important. I love that. Okay.
Let's talk about dry vaginas. So if you have a dry vagina and for whatever reason you're not going to use estrogen, you can use lubricants, and they're always coming out with better and better lubricants. So the lubricants will help lubricate your vagina from the outside, and you know that there is an estrogen in them.
Okay. And for women who can take hormone replacement therapy, but choose not to because they would prefer to do it naturally, for those women, would it make sense? I know that you talked about soy, and Christiane Northrup, she talks about soy as well. And I think it's isoflavone. I don't know if I'm saying that correctly, but isoflavones. And can you use that as a means of potentially diminishing hot flashes rather than taking estrogen?
Yes, and I agree with Dr. Northrup on that account. That's definitely an option. Just don't kid yourself. You are getting estrogen. That's how the isoflavones work, is that you are getting some estrogen.
Okay. Okay. And then for women who have been told to avoid estrogen, avoid soy.
Yeah. I
Okay.
mean, if you're eating tofu even a few times a week, and maybe you like a soy milk latte once a week, that's not going to be too high. But you can see in blood work higher estrogen levels in people who just start, daily really increasing their soy intake.
Okay. 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 Well, I know we've been chit-chatting. I still have so many questions, but I know we've already been chatting for quite some time now. I think we're probably close to 50 minutes. So I know that you can't treat Canadian women inside the community, but if there are, I know we do have a lot of American women that are members of the community. How can they how can they reach you? And then I'll quickly look at some of the questions that are coming in, and if you have like 2 more minutes, we'll answer one or two.
So
How do
I
people
have all
find
the
you?
time. I have all the time, and I'm happy to stay on here as long as my assistant knows to come and get
Okay.
it if something happens. It's 1:18, so I should be. He will knock on the door. Trust me.
Okay. Okay.
Thank you for being respectful of my time. Uh, did we answer all the questions from before?
Let me just quickly review here. So I had is it safe? We talked about bioidentical versus synthetic. Are there any potential side effects? I've heard really bad stories of women getting pellets, like where they do an incision and then they stick pellets, and then and I've heard some really bad stories. Have you ever heard of that? And is there that's one of the questions, is like, should you take pills? Should you use creams? Do you put the creams on your body? Should you do them like vaginally? What about the pellets? What are your thoughts and your practices there? That would be a really good one, I think, that would be helpful.
I would love to talk about pellets. And you
Okay.
asked how to reach me. I'm going to put my card up here.
Okay.
I'm in Austin,
Whoops.
Texas, but don't let that deter you.
Go closer to your camera because it's blurry.
I can see you
There
from
we go.
anywhere in the US.
That's perfect. Okay, so everybody write that down: 512-391-9400, and you can see www.freemanmedicalclinic.com. So if you're in the States, now you can reach out to Dr. Freeman and figure out your own personal path with HRT, if that's what you want to do. But yeah, let's get back to pellets and creams and various applications and what you do and what you recommend.
And you'll be one of the first people to know if I decide to get a Canadian medical license, because I think that would be really fun.
That would be awesome.
So how do we get this stuff into your bodies? I'm not a fan of the pellets, and that is not a just natural bias like the other bias I admitted to y'all. I don't like the pellets because they can really scar you. They go right in that beautiful curve of your gluteal muscle, right where that, where it's like a little cantaloupe and just right in there is where they put it. So it can be disfiguring. Both men and women have complained much about that. It's a painful procedure. I speak from experience because when the pellets first came out, I was super excited about it. And I was just starting to go through menopause. So I tried it myself to see what it was like. Painful, very expensive. But what I really don't like about pellets is that you can't control the dosing. So you get a pellet placed, it's 4 to 5 months. So you get it put in, it's a fixed little ball of medicine in there. And so people feel great for a couple of months, and then you have to wait for it to wane off and completely go away. Then you get another pellet. So if you're not feeling good, you can't remove the pellet. It's in there. So you just have to suffer, or you feel great again, and it diminishes off. The opposite of that is the estrogen patch. And this is, whoa, one of my favorite things in the whole wide world. The estrogen patch is the way you want to get your estrogen if you can handle the patch. So the patch is little. There are different sizes depending on the manufacturer. You can put it anywhere on your body. We don't recommend putting it on the breast because in case it does increase the risk of breast cancer, but just about anywhere else, you could probably put it on your forehead. Usually women put it on their arms or their abdomen. You can swim with it. I have a triathlete who has her estrogen patch. You can sweat like crazy down here in Texas, trust me. We're all sweating with our estrogen patches, but the patch delivers a constant amount of estrogen. This is bioidentical because that's how our bodies did it from our ovaries before. When you get that constant delivery, it's more even. So it's more evenly for your moods, for your sleep, for your hot flashes. It's not sporadic at all. And for us natural people, much less medicine, much less estrogen overall, because it's this steady state. But there's nothing wrong with a shot, usually once a week. My transgender patients a lot of times prefer a shot. I don't know why. Sometimes they don't like the patch so much. They like a shot once a week. There are pills that you can take. There's a gel that you can apply, or we can have a non-pharma, meaning not just ready off the shelf product. We can have a compounding pharmacist make the estrogen in a topical or an oral as well.
Okay. I would be a fan of the patch because I'm really bad at remembering to take supplements.
Yes.
And I hate swallowing pills, so I'd be all about the patch.
And you change it once a week. You just take your patch off and slap a new one on once a week. You just set it on your, every Sunday or whatever. Yes. Yeah.
Yeah. Okay. That's good to know. I'll tell you some of the, Sheila said, I need testosterone, exclamation point, LOL, OMG, tired of being tired and the foggy brain and weight gain. Yes. Okay. Michelle asked a question, which I'm pretty sure I already know the answer, but how do you know the dose to take? So I'm assuming that you do you said it, that you do testing and so respond to that and tell us how you test, because the test that I'm most familiar with is the Dutch test, but I would love to know how you test women and what your process is. Like if I call you up tomorrow and I'm like, I think I want to get on some hormones, what's the process? What does it look like if I'm doing that with you?
When I first started prescribing hormones and learning about hormones, fortunately, that was covered in that long weekend course to only do saliva testing. So a saliva test gives you a result of hormones and even things that aren't just hormones, but like adrenal health. It can check thyroid. Could check a lot of things over time. So it's a swab that you do at home. You can send it into the lab from your home. You don't have to go to a clinic. We do it here in the clinic too. But the saliva test, when a doctor is starting to learn hormones, is the best, because you start to really learn about not just the obvious things that progesterone does, what estrogen does, what testosterone does, but you start getting into the subtleties. And often these labs have naturopaths attached to them. And the way I did it is I mean, I leaned heavily. I knew the naturopaths at this ZRT lab out of Beaverton, Oregon. Of course, this is many years ago, but they were so helpful and answered my questions. They were very patient, and I learned so much. Now I'm decades into it, and there really isn't that much variation among women going through perimenopause and menopause. There's some, but it's pretty much, I haven't really drilled it down. I would say there are probably 6 silos, and the woman is going to fit into one of these 6 silos. And I've done it for so long now that I rarely do a saliva test anymore, because with a good history and physical, looking at the woman, listening, taking all the notes, getting as much info. I mean, I exhaust these women. It's so fun because, people like to, oh, doctor is always in a hurry. And I'm always like, oh, but this other thing. And I'm like, anything else? Could you tell me more about that? Sometimes women are like, I've got kids to pick up. Like, can we wrap this up? I'm like, okay, but the more information I have, clinically, I can probably tell you what you need. But then I have the women do a blood draw, because safety first. So I want to see, I'm probably going to check, unless your family doc has already done a thyroid and you've never had a thyroid problem, I'm not going to check your thyroid. I don't need to. But thyroid needs to be up to date. Estrogen, I don't even check a progesterone level, and I'm not going to go into why. Just trust me that it's not necessary. And testosterone. And they're all probably going to be very low or literally 0. Sorry, you can forget the thyroid. So probably you're not making estrogen or testosterone anymore, or they're very low. So I'm going to go ahead and replace those, but I'm treating the human. I'm not treating lab results. Okay. I follow labs to keep you safe. So I don't want you to have too much estrogen, and this is for my transgender patients and my menopausal patients. I don't want you to have too much estrogen, because that maybe could be harmful. I don't want you to have too much testosterone, that could maybe be harmful. But the fun thing is, I can tell you from hundreds of thousands of women I've helped at this point over the years, it takes very little, whether it's testosterone, estrogen, or progesterone, for you to feel like you did in your 30s, in your early 30s. I want you to feel like you did when you were 33. I want you sleeping like you did back then. I want you to have the sex drive that you had back then. I want your vagina to feel like it did back then. All of your ability to lose weight, all of these things. We're really going for the early 30s here. And once
all of the women right now are like, yes.
Yeah, and you can, and let's go. I'm 57. I'm going to be 58 on November 1st. I feel, in some ways, I feel better than I did in my 30s, because we have wisdom now, right? We have probably a better 401k plan, shit like that. Yeah, and I want y'all to hear this. It's possible. It's entirely possible to feel incredible with hormones, and it takes very little.
Yeah, you don't have to struggle through. Okay. Here's an interesting question. I think this is about nootropics. I don't know if that's something that you've ever like researched into, the topic of, I think that's how you say it, nootropics, like the methylene blue. Have you ever heard of methylene blue? I think it's a nootropic, but Judy, you'll have to like just maybe comment on that and tell me if I've got that right. To reduce the frequency and severity of hot flashes. So I guess this is another one where it's like a potentially a different route. We'll come back to you, Judy, on that one. Okay, here's an interesting one, and I would
Hold
love to
on, hold on
hear.
one second. I just want to make darn sure my assistant knows that I'm.
Okay,
Josh? If you need me, just knock on the door. You were saying-
okay. So here's a question that I'm very curious to know your answer to, and we're going to keep it to the topic of sex hormones because that's kind of what we're talking about here. But can you support hormonal balance of your sex hormones with nutrition? Is there any, like, what's your thoughts there? Like,
No,
can nutrition help balance out your or regulate your hormones?
can help. Yes. Gonna fix? No.
Mm-hmm. Yeah, yeah. And I think it's kind of like going back to the soy, right? I think that when it comes to sex hormones, my sort of understanding is that, like, as you go through menopause, like, and as you're aging, you're producing less. It doesn't matter how much soy you eat, or whether you're eating yams for progesterone. Like, it's not the same as what your body used to produce. Is that correct?
That is correct.
Okay.
That said, I think those of us who are taking hormones, or those who choose not to take hormones, most humans, maybe all humans, want to age as well as we can. We want to be comfortable as we age. We want to feel good, right? And diet and nutrition are super important for that. And diet and nutrition is involved with hormones. So I don't want to act like it's not a factor. And my whole anti-aging thing and how I help women age well, like very diet and nutrition focused. But could you eat enough yams and soy if you like? I've never seen that. And why would you want to do that instead of just taking a little bit and having a more varied diet? And you know what I've never thought of before is, are there any foods that are rich in testosterone? By this time tomorrow, I'll know the answer to that. That's what I'm doing tonight, is I'm looking that up.
Yeah.
There's a question.
Well, I haven't seen anything about testosterone. I have what I typically talk about nutrition and lifestyle. So with testosterone, I'm like, you need good sleep. You can't be stressed. You need to work out.
Yeah.
Those are kind of like the big three, sort of like that I understand. And then sex hormone binding globulin, that can be impacted by blood glucose, I believe, right? And so that could potentially have a big impact. And I don't know if I'd be able to explain it properly. Is that something you feel comfortable explaining, or I could do the research and explain it another time?
I would love to do this again and talk about nutrition and diet. I think that would be super, super fun.
Yeah, that would be amazing. Okay, let's see if there's one last question here. Okay, we talked about all of those. Okay, one last question. One thing that I have definitely heard in the space is that it's potentially not good to take estrogen without progesterone, because you could put yourself in a position of being estrogen dominant, and then the potential impact of that. What's your thoughts on that?
Yeah, so what they're referring to is the increased risk of endometrial cancer, and that is a fact. That is absolutely true. If you still have a uterus, you do not want to take unopposed estrogen. Unopposed estrogen means estrogen without progesterone. So if you're on estrogen and you have a uterus, you also must be on progesterone, because the progesterone keeps your endometrial lining from getting too thick. And if your endometrial lining is proliferating and getting too thick with estrogen alone, we know that increases your risk for uterine cancer.
Okay. And that would be the Prempro?
Prempro is a combination of estrogen and progesterone. Or if you're doing bioidentical, we will prescribe estrogen and we will prescribe progesterone along with that.
And not progestin. That's the one that is not really, is that the one that isn't recommended as the progestin, or does that not?
I think progestin is a pharma bioidentical progesterone. Give me one.
Okay, the names all get so confusing. Okay, let's see if there was any other while you look into that.
I've heard of progestin. I think it's a name brand type of progesterone, but it's not in Medscape.
Okay.
I don't think I'm going to be able to answer that question, sadly.
That's totally fine. That's totally fine. And there was one more woman, and I think that's it once we've done this one, but she was saying that her oncologist told her that I guess no, we've already covered that actually. What about recurrent DVTs? I have read you should not take if at risk.
Yeah, so estrogen increases blood flow, but I don't want to get too sciencey. Estrogen, we've always known that women on birth control pills that have estrogen in them are at a higher risk of developing a blood clot, because with this better circulation, as far as estrogen is concerned, also comes this higher risk of having a blood clot. We've always known that. Other things that increase your chances of developing a blood clot are smoking and age over 30. So like women over 30, if they're smokers, if they're on the birth control pill, we try to give them a progesterone only or some other form of birth control that doesn't have estrogen in it because of that risk. We are learning more and more all the time about clotting factors. So you and I have, let's say, each have 4 quarts of blood coursing through our body. And when we get cut, the blood clots. So we don't just bleed out, right? It clots and it stops. But there are all these little clotting factors in the blood. You may have heard of things like factor IV Leiden deficiency, all kinds of clotting disorders. So if you have a clotting disorder and you don't know about it, and you take estrogen, you can have a stroke. Like that does happen. Like females, I've had a couple even in the years that I've practiced. Women in their late 20s having strokes when they're on the birth control. Well, we used to blame the pill, and things have really improved with the pill, by the way. Like the birth control pill now has a micro fraction of the amount of estrogen that it did when it was developed in the 60s. But so did that answer the question?
I think so. Yes, I think so. What I'll do is if there's any questions that went unanswered, I will let you know. But I would love to talk about birth control with you at some point too, because I know a lot of women are prescribed birth control in perimenopause to treat their signs and symptoms. And I don't know if you think that's a good route, or if they should jump on like hormone replacement therapy. I again would love to dive into that at some point with you. But
Me
for the
too.
ladies that are still here, can you all give me like a big thumbs up and a big thank you to Dr. Freeman for jumping on and would be Michelle said, what an amazing hour of learning. Thanks to both of you. Getting thumbs up here. So thank you so much. So much. I will make sure to getting lots of hearts as well. So huge thank you. Thank you. I know this is going to help a lot of women and just help them. And I'll make sure to get your phone number up. There's a lot of women that couldn't join live, but I know a lot of women have requested the replay. So thank you for spending time with us today and going through that, because I do think that it's such a misunderstood topic, and I think a lot of women struggle through menopause unnecessarily because of that. So once again, ladies, I'm gonna shut down the live stream now. Thank you for joining us live, and I will see you all soon. And Dr. Freeman, I'm going to say thanks to you once I've stopped this live stream here.